Role of gastrointestinal endoscopy in the screening of digestive tract cancers in Europe. European Society of Gastrointestinal Endoscopy, ESGE, Position Statement. Introduction. Mostly because of the aging population and environmental risk factors, gastrointestinal GI cancers represent a significant burden for European citizens, comprising 1/4 of all the malignancies diagnosed in Europe. An estimated 600,000 cases of GI cancer and 360,000 related deaths per year occur in the European Union. Moreover, when diagnosed in a symptomatic phase, most GI cancers are still associated with a dismal prognosis. The 5-year survival, as estimated for 2000 to 2007, was 41% overall, varying according to site of diagnosis. 12% for esophagus, 24% for stomach, 48% for colorectum, and 6% for pancreas. In addition, late-stage cancers represent an economic and financial burden because of palliative treatment and new biological treatments for advanced disease. Better understanding of the natural history of GI cancers has shown that most of them are preceded by slowly progressing precancerous conditions or lesions, as well as by early invasive stages, therefore providing opportunities for effective interventions. Beyond the classic adenoma-carcinoma sequence for colorectal carcinogenesis, similar pathways based on metaplasia, dysplasia, cancer progression have been shown for upper GI as well as pancreatic cancers. In addition, advances in knowledge about genetic factors have led to the identification of the pathogenetic mutations responsible for familial GI cancer syndromes. In this area, the application of endoscopic techniques to the GI tract, i.e. gastrointestinal endoscopy, represents a set of unique techniques for early detection of cancer or precursors, followed by potential endoscopic interventions. In fact, endoscopic resection of precancerous and early lesions has been associated with reduction of incidence and very high 5-year survival rates. Besides, it is usually preferred by patients because it is less invasive and less costly than surgical treatments. Moreover, endoscopic and histological diagnosis of precancerous conditions leads to an effective risk stratification of the endoscopy population, with appropriate adjustment of surveillance protocols to those high-risk patients who may benefit the most. In this document, ESGE aims to summarize its position regarding the current role of endoscopy in screening for the diverse gastrointestinal neoplasms and to support the role of digestive endoscopy in the reduction of cancer incidence and mortality. Methods. In 2017, the European Society of Gastrointestinal Endoscopy, ESGE, Governing Board, established a task force, public affairs working group led by AS, to produce a position statement concerning the value of endoscopy for screening purposes in GI cancers. The most prevalent digestive cancers, esophageal squamous cell carcinoma, esophageal adenocarcinoma, gastric carcinoma, colorectal cancer, and pancreatic cancer, were considered. Using a structured PICO framework, population or patient, intervention or indicator, comparator or control, outcome, detailed literature searches were performed by an expert task force, yielding results through a modified Delphi process that are summarized in recommendations or statements. The PICO items were defined regarding the role in terms of prevention, survival, and cost-effectiveness outcomes of digestive endoscopy technologies. Upper gastrointestinal endoscopy, colonoscopy, and endoscopic ultrasound, EUS, interventions and comparators, in 2 different settings, populations or patients, namely for the average risk population and for high-risk groups or settings defined by geography, ethnicity, individual exposure, or family history. This excludes the specific management of individuals with known hereditary colorectal cancer syndromes or with known precancerous gastric lesions as considered in previous ESGE guidelines. Epidemiological data were taken from online databases available from international studies. Pooled national estimates have been used, derived from European incidence and mortality data in 2018, provided by the Joint Research Center and European Network of Cancer Registries. Incidence time trends in 2004 to 2010 are based on observed rates from a pool of population-based cancer registries and are available from the same database. Histology-specific data for esophageal cancer were available from the RareCareNet database on incidence and survival for rare tumors in Europe. Survival data were downloaded from the EuroCare 5 project database. Statements. First statement. For average-risk populations, ESGE recommends the implementation of organized population-based screening programs for colorectal cancer based on fecal immunochemical testing, FIT, targeting individuals, irrespective of gender, aged between 50 and 75 years. Depending on local factors, namely the adherence of the target population and availability of endoscopy services, primary screening by colonoscopy or sigmoidoscopy may also be recommendable. Second statement, in high-risk populations, endoscopic screening for gastric cancer should be considered for individuals aged more than 40 years. Its use in countries or regions with intermediate risk may be considered on the basis of local settings and availability of endoscopic resources. Third statement, for esophageal and pancreatic cancer, endoscopic screening may be considered only in high-risk individuals. For squamous cell carcinoma, in those with a personal history of head or neck cancer, achalasia, or previous caustic injury. For Barrett's esophagus, BE-associated adenocarcinoma, in those with long-standing gastroesophageal reflux disease symptoms, that is, more than 5 years, and multiple risk factors, age 50 years or older, white race, male sex, obesity, first-degree relative with BE or esophageal adenocarcinoma, EAC. For pancreatic cancer screening, endoscopic ultrasound may be used in selected high-risk patients, such as those with a strong family history and/or genetic susceptibility.